Hello everyone, how are you all? Welcome to First Aid MC Clinical, free 2-week sessions again. I hope that you guys are enjoying our sessions so far. It's been a lot of classes this week, right? So you guys might be a little tired of classes because there was another class yesterday with Dr. Tasrifa, right? How did it go? Did you guys like it? Good. So that's how usually we will take classes also. It will be most likely three classes per week. Okay, so in this case, 2 classes will be taken by me and another will be just a role play session, just like yesterday's. And that's really a great inclusion to our course. Previously, I don't know if you guys know or not, but previous batches, they did not get this thing. We started this one in the middle of the previous batch. And so it's really good. Nowadays, I'm taking role play sessions with you. She's taking role play, just role play with you. So lots of role play sessions are there, and you get to know the cages and you get to know the approach, and you can see that other people's how they're approaching the cages, and that's very important. We not only learn from just listening, listening to our mentors, also we learn a lot of things we learn from our peers as well, just by seeing that how they're approaching. And when we were preparing for clinical exam, we also learned a lot from our study buddies, our study partners. So this is how the learning should be. It's not just one guided, it's a multiple people who will contribute to your success in the end. Okay, so try to gain those sort of things, try to take those things which is good and nice. That is the important part. Always keep your eyes and ears open. Wherever you get some free things, just go there, listen to them, and that's very good. Okay, and if you like something, then you get into that to get into the end of the particular program. Okay, so this is how in Australia we also learn, right? I'm still learning, so it's still this lifelong learning journey will go on and on for doctors like us. So this is one of the important things. So I wanted you guys to get into an adaptation with our classes. That's why I kept yesterday's session, and I was driving actually yesterday. Otherwise, I would first start and then introduce Dr. Tasrifa with you, and then she can start. But at the time when she started, I was driving back to home, so I could not. That's all right. I guess she did great. And so let's start our cardiology role play session today. Yesterday's class will not be uploaded to the YouTube. Okay, I'm really sorry for that. It's may not be uploaded, but let's see if I have to go through the session, and then if everything is good and everything is all right, then I might upload it, but may not be uploaded because we don't upload the role play sessions in YouTube in the public things. Okay, so might not happen. Okay, but I guess all of you attended the session, it should be fine. Okay, so let's start our tonight's sessions. Tonight's session is on cardiology, and we already finished cardiology. Just a small bite of it is left, right? And that was your CVS risk assessment. I want to go through that pretty quickly with you, and then we can start the role play. Yes, those in the course, so you guys will already should get a video recording by tonight in the software. Okay, Dr. Romnek. So I already uploaded that, but the team might take some time to upload it in the software. So you might get it tonight, most likely. Okay, so before I start the cardiology role play session, I might just go through that left CVS risk assessment with you in a very short time, and then we can start it, because I don't want to keep this one left. This is important topic. Now, CVS risk assessment, all of you has gone through this particular thing, and remember the chart that we used to cover in our MCQ exam. So that CVS risk chart now is coming as a history and physical examination. And sometimes they even ask you to explain what you can find out in that CVS chart to the patient, or sometimes even to the medical student now in online exam. So let's discuss this CVS risk assessment, how we usually assess someone's 5-yearly CVS risk by asking some questions. That's all about this case. So you are a GP, a middle-aged man come to you to have a consultation after his brother went for coronary bypass 2 weeks ago. He is obese, no other past medical history. Your task is to take a focused history, and they usually ask like, history should be related with CVS. So focused CVS history, physical examination from examiner, if it's a face-to-face then, or if it's online, a lot of things can happen, right? So they might give you a physical examination card, they might ask you to explain to a patient, or explain to a medical student, or explain to an examiner. So a lot of things can happen in online exam. Explain what will be the initial management also. So, okay, let's start. In here, there is no CVS risk assessment chart given. There are questions in where you might get the chart and they can ask you to explain it. We'll go through that very quickly also. Yes, so this is your ABCDEFS risk assessment mnemonic. So you just need to remember that. Now, obviously, you don't just start with like, do you drink alcohol, John? So this should not be your first question. So how we should start in here? First, look at the question. Always in the question, if you see something which is sad, like this patient's brother had a coronary bypass surgery, you should always address this issue with the patient, and patient will also be happy with you. That means it means that you care for this patient, not only for the patient, also for the patient's surroundings. So say that, hi, John, this is Dr. Ashan, one of the doctor here. Now, what do? You lower down your tone and you say, I'm really sorry, John, that I got to know from the notes that your brother had a bypass surgery 2 weeks ago. You must be really stressed. How is your brother doing now? Is he fine? Yes, doctor, thank you so much for asking. See that this is a rapport you're building with the patient, which is super important for not only your exam, but also for your general practice, for your lifelong practice you will be doing as a doctor. So it's important. Always try to address these things. It's very important. And then you start saying that, John, I know that you are here today to discuss something with me, but would you please tell me a little bit more about like why you are here today, or how can I help you today? Do you have any particular concern? Because you can't find out like why he's here, right? So you can ask the patient, like, don't say, why are you here? You can say in that way, John, I understand obviously you are here for a reason. Would you mind telling me like what is your main concern today? I'm more than happy to help you in any possible problem that you are having. So then John will say, Doctor, my brother had this surgery in regards to the heart problem. I just don't want to have something like that. So I want to know that if I am having any risk and how I can prevent myself from having a bypass surgery in future. So appreciate the patient for that. Say, oh, that's really good. I really appreciate that you are here for that reason. I'll be more than happy to help you. So John, I'll be asking you some questions in regard to that, and then we can find out a proper plan for you. Is that okay with you if I ask some questions? Yes, doctor, that's fine. Okay, so then you go into your questions. Okay, now you can use your ABCDEFS format in here. Now, what I would say, you can start with some CVS related symptomatic questions first, followed by going to the risk. Like you can say at the moment, are you having any chest pain, shortness of breath, racing of your heart? Okay, how's your general health normally? Okay, so just ask some symptomatic questions related with heart. Once you have done that, then you start going for risk assessment question. ABCDF, A for alcohol, B for blood pressure and body weight, C for cholesterol, D for diet, and E for exercise, F for family history of any diabetes, hypertension, or heart disease, S for smoke and stress. So these are the ABCDEFS questionnaires for risk assessment that we'll be asking to the patient. So you can start asking, so John, please tell me a little bit that do you smoke or drink alcohol? If yes, then always ask in detail that how many drinks a day, okay? How many cigarettes a day and how long you are drinking, how long you are smoking. So ask those questions if there is any positive findings. Then ask the B for blood pressure and body weight. So you can ask the patient, do you have high blood pressure? Do you know your body weight or BMI? Some patients knows their BMI, so you can directly ask them. If they don't, then don't bother. Don't go for explaining BMI. Just say, well, I will explain it later. Don't worry. C for cholesterol. Do you have any history of high cholesterol? Any family history of high cholesterol? You can also ask. D for diabetes and diet. Any history of diabetes? Can you explain your typical daily diet to me? Do you have a healthy, balanced diet? Do you do any exercise? That's E for exercise. F for family history. Any family history of high blood sugar, high blood pressure, or any heart disease? You already asked smoking, then you ask about stress. Any stress at your home? Who do you live with? Are you a happy family? Do you do any work? Any stress at your work? Do you have any financial issues? So stress is very important part of ABCDEFS. And lastly, just finish with any other past medical history, any surgical history, and any medication are you on? Okay, so that's how you finish these questions. Very easy if you remember in ABCDEFS format. Sometimes they ask physical examination from examiner. If you are in a face-to-face exam, you have to ask this from the examiner, and examiner will give you those findings, which will not happen in online. I'm saying it again and again so that you get an idea about it. Lots of candidates still don't know how face-to-face and online exam usually occurs. And that's a confusing part also, I understand. So throughout the course, we'll go through both face-to-face and online so that whatever your mode of exam is, you will be ready. Okay, that's important. Now, if you're going for face-to-face and you need to ask physical exam from examiner, then you will ask in this way. You can use the same format for online exam also, just how you explain it will be different. So in the physical examination from examiner, so you say, dear examiner, I would like to do a physical examination on my patient. I would like to know the general appearance. In general appearance, you look like as a whole how the patient looks like. So is he comfortable? Or can I see any visible sign of high cholesterol like genital asthma, xanthoma? Okay. Now, if you don't ask it here, but you ask anywhere else, that's also fine. But just remember, like in here, it's important to ask about genital asthma, xanthoma, and corneal arcus, because this gives features of hypercholesterolemia. So any sign of high cholesterol, you can ask. Pickled, ask very quickly, pallor, icterus, lymphadenopathy, edema, dehydration. Ask the vitals, very important. Which one is very important in vitals? Blood pressure. Okay. Ask about the BMI, that's also important, right? That's your B. ABCDEFS. So that's your BMI. Then very quickly go to the CVS respiratory and abdominal examination. And lastly, finish with office test. Urine dipstick BSL is very important because that will give you diabetes D and ECG. At the end, ask the examiner that is there any 5-yearly cardiovascular risk assessment chart available or not? Okay, so it's important to ask it because sometimes they can give you if you ask. If you don't ask it, they will not give it to you. But in this case, most of the time they don't give it to you. They just say it's not available. That's fine. But you should ask it because this is how you will assess the risk through a graph and you can show it to the patient. Okay. So this is how you will do the physical exam. Don't bother with the CVS respiratory and abdomen that what you are going to ask because we will discuss it in detail during each of the system when we will be doing in our course. How to explain? It depends on history, what you have found out. So some of the positive risk factor you will be getting. So just address those issues. So say that Let's say we have got high blood pressure, high body weight, diabetes. So we will just discuss that. From the history and examination, John, I have found some risk factor that can put you in a high risk of having a heart-related complication in future. Like you have high blood pressure, your body weight is higher than normal, you have high blood sugar or diabetes, your diet contains fatty food rather than healthy balanced food, and also you have been smoking for 20 years. All this can put you on some risk of having heart-related complications. Please don't worry. We can. Someone's microphone is on. All right, sorry for it. Please don't worry. We can prevent this complication by adapting healthy lifestyle. I would advise you to cut down your alcohol to safe level. Try to maintain an ideal body weight. Avoid smoking. Take healthy balanced diet. Do some exercise, ideally 30 minutes of brisk walking, at least 5 days per week, and try to avoid stressful works. That's your like SNAP. Okay, so SNAP means like every time you give some healthy lifestyle advice, SNAP should be covered, which means no smoking, no alcohol, okay, and physical exercise and nutrition. Okay, so this is important. So no, if patient is drinking, don't say stop drinking, just cut down alcohol to the safe drinking level. That's fine. Smoking should be totally avoided. Nutrition is very important, so healthy balanced diet and physical exercise. This 4 is must. And then there is investigation. You need to order some basic investigation in terms of CVS risk assessment. What are those? Full blood examination. You can do a kidney function test, liver function. Very important is these 3, is ECG, BSL, and lipid profile. Because without having this, you can't put this patient on the CVS risk assessment chart. Because if you remember the CVS risk assessment chart, it looks like this. So you need to know, is this patient having diabetes or not? You need to know the cholesterol HDL ratio. So that's why you have to order these things if it is not given already. So blood sugar, we need to know. We need to know the lipid profile. These 2 is must. And also the blood pressure. And lastly, say 4R. 4R in here, remember the 4R we have been talking about? This is a good time to say 4R. So 4R is review, referral, red flag, and reading materials. So you say that you will be reviewing the patient once these investigations are done. At the moment, no need of referring to anywhere. Red flags, obviously you can give a red flag, like as this patient having some risk, you can say at any time you are having chest pain, which is left-sided, and you're also having shortness of breath, nausea, vomiting, excess sweating, okay, please call the ambulance or go to the emergency department. Just the red flag is about cardiovascular complication, like a MI. So you can just give those red flag and give reading materials about CVS risk assessment and also lifestyle modifications. Okay, so in here, review, red flag, and reading materials. These 3 are important. No need to refer at this time. Cool. So that's how you will finish this case. In this case, if CVS risk assessment chart is not given in your physical exam, you can address that issue in here, that once the investigations results are back, then you will also put all these results in a graphical chart to give you the absolute risk in the next 5 years. So you can just use that line that you will use the results of blood sugar, lipid profile, and then you will assess the 5-yearly risk for this particular patient. That's a good idea to add in here. Now, sometimes in a scenario, they might actually say that they will give you all the finding and they will ask you to put this finding on the risk chart and then explain this chart to the patient and further investigations and management. So that's a little hard, but you should know how to do that because we don't know which will come in your exam. Now, for CVS risk assessment, some of the things you need to notice that what is the age of this patient? Is it a male or female? Is it a smoker or non-smoker? We need to know the systolic blood pressure. We need to know the cholesterol level. So these are the things that you will notice. There will be a long question in here, obviously, but you need to just find out these 5 things. And also sometimes they can give you this patient diabetes or not. Now, look at this one. Let's say you have got this chart, people without diabetes, men and women. So this patient is a man, as I know, and then you can get it as a 57-year-old. So this is a 57 years. So look for the ages. This is 55 to 64. So we will be looking for this one. Now, this patient was a smoker, right? So he is a smoker. So we'll be looking for mainly this particular area. See that the important thing is to find out the specific area where you should be looking and just forget about all other things. Now, you need to know that this patient's systolic blood pressure is 160 and cholesterol is 8. These two, we will need to put it in the graph. Now, the important part first, let me describe one thing that in your y-axis, this is the systolic blood pressure, and you can see 120, 140, 60, 79. Let's discuss about this particular box, the lower left one. What is the highest number you can put in terms of systolic blood pressure in this box? Is it 120? No. The highest you can put it here is 129, means that less than 130. Same in here, 150 is the highest. That means not 150, less than 150. This one is less than 170. So don't think that up to 120 is the box highest limit. The box highest limit is up to 129. Okay. Now in your x-axis, there is cholesterol HDL ratio. As you can see here, 4, 5, 6, 7, 8. Now, what is the maximum limit or maximum number you will put it here in this box? Is it 4? No. Up to 4.5. That means less than 4.5. Okay. So less than 4.5 in here. Then in here, 5.5, 6.5, 7.5, 8.5. Okay. Is this clear for everyone? This is very important because sometimes they might not give you like exact like 160, which is easier to find out. Let's say they gave you 145, then where you will put it. So that's important to understand that what is the highest limit of a particular box. Now let's say our patient having a systolic blood pressure of 160. This is 160. So we are looking for this part, right? Now let's say cholesterol HDL ratio, the cholesterol is 8. So obviously we are getting up. So this one, this reddish one, this is where this patient is right now. So now compare this color in here. You can see the red means it's very high risk, more than 30% risk of having a cardiovascular complication in the next 5 years. Okay, so this is how you have to explain to the patient also. Yes, so the blood pressure one, let's say this is your box. What is the highest point of systolic blood pressure in here? Up to 129. Okay, for your better understanding, let's keep it 130. Then this one, the highest limit will be 150, 170. Okay, so it's not 120. That's the main point that I want to discuss. Don't think that the maximum systolic blood pressure in this box is 120. Maximum is up to 129. Okay, when it becomes 130 and above, then we put it here. Cool. So that's what you need to explain to this patient. So you can explain to the patient like this is a graphical assessment of your 5-year risk of having a heart-related complication. In this graph, you can see that it's a graph for both men and women, and that's mainly for people who doesn't have any diabetes or high blood sugar. Then we look, if it's a man, then we look for, is this person is a smoker or non-smoker? Let's say you have been smoking. So we'll be looking for this area. And then in here, in the vertical area of this graph, you can see this is where we put your blood pressure, which is your systolic blood pressure or the upper part of your blood pressure. And in the horizontal area, you can see it's your cholesterol level that we have to put. Now, according to our examination and the results of the investigations, I have found that your blood pressure, and also you can add this age group as well. Okay, I have found your blood pressure, upper limit of your blood pressure is 160. So we are looking in this particular point. And then also I have found your cholesterol level is 8. So just we go up like this and we find out this specific point. The color in here is red. So we compare this color in here and we see that in your case, it's red color. So you are having a more than 30% risk of having a complication. Please don't get scared. It doesn't mean that you are going to have it. Right now, we have 5 years to act on it. And if we start managing you from this point, you will not have any problem, I hope. But we need to work on that. And I need you to follow my advice on further lifestyle assessment. So then you give your lifestyle advice, you do some further investigation and manage the patient accordingly. The thing is that there is no particular way to explain anything. You just explain in a simple way to a patient. It's not after 5 years, it's within 5 years. That means it's called that within the next 5 years, what's the risk of having a serious related complication in this patient? It doesn't mean that patient will have like after 5 years. It can happen at any time. We don't know that. That's right, Dr. Farasha. Yes. Cool. So that's pretty much everything about CV. I think we are done with this cardiovascular system. Let's move on to our role play sessions. Okay, who wants to go first? Dr. Maliha, so let's start. Okay, we'll try to go through. So let's start with Dr. Maliha and then we'll see that how long we can do. Let me unmute you, Dr. Maliha. You can hear me, right?
Yes. Can you hear me?
Yeah. All right. So this is your question. You will get 1 minute time to like for reading and then 7 minutes inside. Okay. Let's start. Okay, so this is your patient. Your patient name is Jenny. You can start.
Okay. Hi, Jenny. This is Maliha, one of the doctors here. I understand that you had some loss of conscious this morning. So, how are you feeling right now?
Yeah, doctor, I'm good now. Thank you.
Okay, that's really good. So, can you tell me more about what happened at that time?
Yeah, doctor. So I didn't know, like, it was really weird feeling. I never had it before, but I just got up in the morning and just wanted to eat something. So I was going to make my breakfast. I opened my
Mm-hmm.
refrigerator, and then suddenly I don't know what happened. I had a fall, and then I think I lost my consciousness also.
Okay, okay. So, Jenny, really sorry to hear that you had to go through all of this. But is it the first time that you have such an episode?
Yeah, doctor.
Okay. And did you have any feeling like you were feeling dizzy or you were kind of lightheaded before that happened?
I can't exactly remember, but I think like I was feeling a little kind of like lightheadedness, as you say.
Mm-hmm. Okay. Any headache, any blurring of vision before that?
No,
Okay. Any strange smell or any changes in your vision that you could experience before that?
no, doctor.
Any illness like fever or head, neck stiffness, any rash before that occurred?
No,
Mm-hmm. And was there anyone accompanying with you at that time?
no, doctor. I was alone.
Okay, so there was no witness right there.
No,
And do you have any idea for how long did you remain unconscious?
no, doctor. I don't have any idea.
Okay, and when you like got up, did you notice that you had wet yourself or you had bitten your tongue?
No,
Okay, and when you woke up, did you woke up as soon as possible, or did you take a lot of time? Were you drowsy or lethargic afterwards?
no. I was a little dazzled after that, but
Mm-hmm.
I just like it's not too long confusion or anything like that. I
Okay.
started.
Okay, okay, that's good. And regarding your general health, how is your general health? Any past medical or surgical history that I should be aware of?
Not exactly.
Any chest pain or shortness of breath you had experienced before?
No, no,
Any funny racing of heart?
no,
Any um, any headache, any nausea, vomiting before?
no,
Any fever?
no.
Okay, and you said you were about to wake up, make your breakfast. So, did you have your proper dinner last night before?
Yeah, yeah. I think so. Yeah.
Okay, any chance that you skipped your meals?
No.
Okay, and do you feel like is your general health good? You keep diet a lot or not?
Yeah, I'm generally healthy.
Mm-hmm. Okay, and did you have any weakness in any part of body? Any problems with your speech or vision after that?
No, doctor.
Okay. And do you have any personal history or family history of any heart condition or any sudden cardiac death?
No, doctor.
Okay. And Jenny, a few personal questions now. Do you smoke?
Sometimes, but not, like very occasionally with my friends.
Okay. And when you smoke, how much do you take? How many sticks do you take?
Doctor, it's not much, like one or two cigarettes.
Okay. So with your consent, I would like to arrange another consultation if you're happy, so we can discuss about quitting smoking as well. And do you drink alcohol?
Yeah, sometimes. Yeah.
And how much do you take?
Normally just over the weekend I take it, doctor, like with my friends.
So, is there any chance that you take a lot of quantity in one setting, like any binge drinking or
Now that you asked, Doctor, yes, like last night actually, we had a like very big party for, and yeah, we had like a lot of binge drinking that last night. I don't
Mm,
remember much, but probably not a little amount. It was a lot.
okay, and what do you usually take? Like, what kind of alcohol do you take?
Normally wine or beer.
Mm-hmm. Okay. So, just as for smoking, I would like to discuss alcohol with you as well, because we want to discuss what the safe limits are, and because it's kind of necessary to know for your general health. And apart from these, do you take any street drugs?
No, doctor.
Do you take any regular medicines?
No,
Any known allergies?
no.
Okay, okay, that's good. So, regarding your personal life, your cycles and personal life is all fine. Do you have enough social support?
Yeah, doctor, I'm fine. Yeah.
Okay. So the most said Jenny, from whatever you have told me, the and the findings that I found in the history, most likely it seems that the unconsciousness you had was which we call as syncope, and the most probable cause from your history seems to be the alcohol that increased amount you had the night before. That is the binge drink that you had. So it can be a number of other causes, like it can be because of certain cardiac conditions, like can be prolonged QT syndrome or myocardial infarction or aortic stenosis, but they do not seem likely because of your age as well as your history. Can be because of CNS problems like epilepsy or meningitis, but they are not the clues there in history as well as can be
Thank you,
because of
doctor.
metabolic problems.
Thank you. Okay. All right. So thank you, Dr. Maliha. You did good history, and also the diagnosis was good. Now, it's not like a very long case, as you can see. So try to be a little faster with the history. Like when you get all the important things, just move on. Because the thing is, like, you have to touch this point, like at least some of the necessary investigations. See, so if you just like get some, you can be very fast, like asking the history, give the diagnosis and DD and necessary investigation. If you forget something, then you can go back, and if you have some time, then you can ask those history. That will also save you. But if you don't touch this point, then obviously it will be a fail. Okay, so very important to touch all these things. As I gave you 7 minutes, if you are in online, you will get proper 8 minutes, so you will be fine. Okay, but again, try your best to finish it in time.
Okay,
Now, let's discuss this case.
thank you.
Yes, it was a case, no problem. So yes, this was a case of syncope, and most likely cause of syncope was binge drinking last night. The approach was very good, Dr. Maria, like you wanted to uh, have an appointment with this patient in regards to both smoking and also alcohol. Very good thing to say that if you give me the consent, Jenny, I would like to make another appointment in terms of your alcohol, and I would like to talk about it. So always start in that way, like if you give me the consent, then I will do that. It's a very good approach. And your initial thing was good. You asked the pre-syncope, during syncope, post-syncope questions, so that's perfect. You ruled out severe CNS differential diagnosis. You ruled out hypoglycemia, infections, and also one of the thing I want to add here, you can ask postural hypertension in here, even though it's very unlikely for this women. But again, just ask, because she had it during in the morning, you can just ask that, like, do you feel dizzy or lightheadedness, or do you lightheadedness when you change your position, just to add the postural hypertension in your differential diagnosis. I would say for all of you, because it's a 27-year-old female, add one of the important things, which is like pregnancy related complications. I know that we might not added it in our history format, but I think I will add it in the software. You will get a note where I have added that. So at that point, because sometimes it could be an important thing, right? So like sometimes a pregnant patient can have a syncopal attack. It could be due to anemia, or even just a normal female patient can have anemia, and that can cause a loss of consciousness. We don't know that unless we find it out. So at these 2 points, like ask the patient about their last menstrual period. Okay, ask them, is the period regular or not? Are they sexually active? Any chance of getting pregnant at the time? And any early morning nausea, vomiting, or any breast soreness? Just a couple of questions in terms of period and pregnancy and partner. That's a good idea to add in every female in this age group. Okay, so at that point, give a little bit of time about stress-induced or psychogenic syncope. Okay, so you can ask the patient very quickly about like who do you live with, any stress at your home, due to any work, any stress at work. So some stress will be a good idea to add here. In the period question, you can ask any heavy bleeding history just to rule out possibility of anemia. Okay, I think you asked about family history of sudden cardiac death. So that's also important in here, just to be aware that this patient can have cardiac related problem also. And other than that, everything is good history. Diagnosis, I would say that if you say syncope and most likely diagnosis is binge drinking, at least explain why like how binge drinking causes loss of consciousness. That it could be due to, like, it can cause low blood sugar, and that can result in loss of consciousness, because hypoglycemia is a effect of binge drinking or alcohol intoxication. So we can always say in that way. Sometimes alcohol can cause dehydration, lots of alcohol intake, and that dehydration can lead to syncope. Sometimes patient can develop electrolyte imbalance like hypokalemia, hyponatremia because of binge drinking. So that electrolyte imbalance can be a cause of having a syncope in terms of binge drinking. So just explain, because sometimes they like in that way, like why or how a binge drinking will lead to loss of consciousness, you can add it. So that's why, like, we have to be a little quick in our history to get some time to explain in this way. And necessary investigation, just basic test, but don't forget to add some of the important investigation like blood sugar, urine dipstick to look for any urinary tract infection, or dehydration to look for urinary ketone. And we can also order a urine pregnancy test if she's sexually active. Then we can order an ECG. That's an important to do, and just some basic blood tests, full blood count, inflammatory marker, kidney function, liver function, those things. Okay. No, we don't have that much time, Dr. Nirola, to address the issue of smoking and alcohol during our management. Okay, so we don't need to talk about it. You just make another appointment, because this is a whole lot of topic. So we don't have that much time in our management to talk about smoking and alcohol, because that takes like 10 minutes just to consult on alcohol. So you will not have that much time. Drug screen, if it's not mandatory, but we can look for blood alcohol limit, okay, or breath alcohol limit. That's fine. We can order it. PO is seen commonly presenting as palpitation. Yes. Pheochromocytoma will not be important in here. Yes, Dr. Sylvia, you got it. So LMP is important. Okay. All right. So that's pretty much everything that you asked. The investigation, I would say blood sugar level is important. Then ask about urine dipstick, ask about ECG, order some basic tests like full blood inflammatory marker like ESR, CRP, kidney function, liver function. Okay. Any question, guys? Lipid profile is not important for someone having for this age group. Okay, we don't need to order it. So urea electrolyte creatinine, okay, that's an important one. Yes, Dr. Itza. So renal function test should cover it, but again, like you can talk about like urea, electrolyte, creatinine in that way. Electrolyte is important here. Yes, you ask Dr. Amal that always before asking the period question, say that I'm going to ask you some sensitive question. So can you please tell me your last menstrual period, or when was your last menstrual period? Then the second question is your period regular? Then are you sexually active? Any chance that you might be pregnant now? Are you having any early morning nausea, vomiting, or any breast soreness? So these are pretty much the questions in terms of period and pregnancy. Add like heavy bleeding history also in period. Cool. Any question for someone who are in Facebook Live? I can see some of you are there. That's right, Dr. Nida. Like patient will not know that if they had any jerking movement, if there was no witness. So no witness, we don't need to ask it. Even if you ask it, that's fine. All right, so let's do the next case. I think I wanted to do that. Yes, Dr. Arafat. So let's do that. Head injury hasn't been asked. She might have injured her head. Yes, we can ask that. That's a good part. Like we can ask that. Did you any chance you might hit your head? So let me unmute Dr. We'll start with Dr. Arafat now. Okay.
Hello.
Hi, Doctor. Okay, give me a moment. I'll give you the case. So this is your case. You'll get 2 minutes because there is a ECG also in the next page. When you finish reading this one, just say that you turn the page, then I'll turn it. Okay. So your 2 minutes started, and we'll do it for 7 minutes.
Okay.
All right, doctor. So this is your patient. Your patient name is David. You can start.
Okay. Hi, David. My name is Arafat. I'm one of the doctors here. I understand from the notes that you're having some chest pain. Is that right?
Yes, doctor.
I'm sorry to hear that. Before I can find out what's going on, I'll need to take you to the resuscitation cubicle, attach a cardiac monitor, and ask you some questions. Is that okay with you?
Yes, that's fine, doctor.
Okay, David. On a scale of 1 to 10, 10 being most painful, how bad is your pain?
It's 10 by 10, doctor.
Would you like some painkillers?
Yes, that would be really nice.
Okay. And are you allergic to any pain medication?
No.
Okay, I'm going to arrange some painkillers for you. Hopefully you'll start to feel better soon. Okay, David, can you tell me where exactly is the pain?
It's in my left side of the chest, doctor.
Okay, and when did it start?
Just half an hour ago.
And is this the first time it has happened?
Yeah.
Can you describe the pain to me? Is it a dull pain, a crushing pain, stabbing pain?
It's kind of like someone is squeezing my chest.
Okay, okay. And does the pain go anywhere else, like your jaw or your shoulder or anything like that?
I'm having some similar pain in my left arm.
Okay. And is there anything that's making the pain better or worse?
No,
Did you have any nausea or vomiting?
I'm feeling nauseous
Okay. Any shortness of breath?
a little bit.
Any racing of the heart?
No.
Any excessive sweating?
Yeah, I sweat a lot at the moment.
Okay. And any recent flu-like symptoms?
No, doctor.
Okay. And have you noticed if the pain gets worse when you lie down or if it gets worse when you lean forward?
No.
Okay. And have you had any loss of consciousness?
No, doctor.
Any fever or cough?
No.
Any injury to your chest recently?
No.
Have you traveled anywhere?
No.
Do you have a heartburn or like a bitter taste in your mouth?
No, doctor.
Does the pain get worse after eating food?
No.
Do you take a healthy, balanced diet?
Yeah, I try.
Okay. And how's your mood these days?
Yeah, it's normal.
How are you coping with stress at home and at work?
It's all right, doctor.
Okay. And is your chest sore to touch?
No.
Is there any rash on your chest?
No.
Okay. And how is your general health, David? Do you have any medical conditions I should know about, like diabetes, high blood pressure, high cholesterol, or joint problems, anything like that?
I have diabetes.
Okay. All right. And do you smoke?
Yes.
How many cigarettes a day?
15 cigarettes.
And how long have you been smoking for?
I think 30 years.
Okay. And do you drink any alcohol?
Occasionally, doctor.
Okay. And like how much do you drink?
Just on the weekend, like two drinks.
Okay. And do you take any recreational drugs?
No.
And are you on any medication at the moment?
Just on some metformin for diabetes.
Okay. And do you have any allergies?
No.
Okay. With your permission, David, I'd like to arrange another appointment to discuss about your alcohol and your smoking habits. If that's okay with you, with your consent?
Yeah, sure.
Yeah. And do you have any family history of any heart disease or sudden death in the family?
My father had a heart attack at the age of 60.
Okay. All right. Okay. Thanks for that, David. I'm just going to have a look at your ECG findings and then I'll get back to you shortly. Okay. 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 Okay, examiner. This is an ECG of my patient David, who presented with chest pain. On the ECG, I can see the heart rate is regular. The rhythm is the rhythm is normal. The P wave is present. The ST the QRS complex is normal. The ST interval appears elevated, and the QT interval is normal. Based on this, I suspect my patient is having a ST elevated myocardial infarction. Okay. Okay, David. So based on the findings and looking at your ECG, it looks like you're most likely having a condition called myocardial infarction or a heart attack. This is a very serious and life-threatening condition, but it's good that we've diagnosed it early and you've come in at early as well. So basically in this condition, your blood vessels that supply the heart get blocked by clots. And as a result of that, your heart doesn't get enough blood and oxygen, which can lead to serious complications. So try not to worry, you're in good hands. With the right treatment, it can be very effectively managed without any serious complications. Are you following me so far, David?
Yeah, I can't even believe, doctor, am I going to die? Because
No,
I
no,
know that my father died of
you've
a
come
heart
in,
attack.
you've come in at as early as possible, and you're in good hands. You should be totally fine. So I will need to admit you into the hospital and refer you to a cardiologist who will plan for the treatment. At the hospital, the cardiologist might do some blood tests like a full blood count, lipid profile, cardiac enzymes, ECG, a chest X-ray, and an echocardiogram to have a look at your heart and to see what's going on. In the meantime, I'm going to give you a tablet called
I'm
aspirin.
up.
Okay. Yeah.
Thank you, doctor. But you did really good. See that you have the voice of confidence. That's very important. Okay. Now the thing is like you need to read the question very carefully because like there is something which if you don't read it properly, you will miss the whole station. Like this one, if you look at here, first of all, when you read a question, look what is the setting you are in. Like, are you in the GP clinic? Are you in the emergency department? If you're in the GP or emergency, is it in the tertiary hospital or is it in the rural area? So this is important because if management is a task, you need to know where are you, because that's how you manage the patient. Some of the patients we can't manage in GP setting and we can't even admit them because if we need to admit, we need to send them to a hospital. Now, you're a GP in a rural area, the nearest hospital is 4 hours away and you have no option to transfer at the moment. That's a problem.
Yeah.
Like this is like real problematic area, right? Like how we can like at least manage this patient at this time. Normally, like it's very rarely like there will be no hospital surrounding this GP clinic. There will, like most of the time in Australia, there will be some hospital, even a rural ED will be there. But there are remote areas where there is nothing, like miles and miles, there is nothing. So that's a place like that. You are in some place like that, and how you can manage such a patient, that's their point. So
Okay.
in here, first of all, the ECG is given outside. Okay, that means you need to ask at least like sometimes there are questions which are two paced or two screen, you can say. So you just ask the invigilator in the online exam that can I please see the next page? Just say ask them. Then in that case, as it's written in here that ECG given outside, that means it's in your stem. You don't need to wait for coming to this task and then look at the ECG, because if you know the ECG initially, then you already know the case and your management comes under your own hand and you already know what you're dealing with. So these AMI cages, most of the time ECG are on the screen or on the outside. You will already know that this is a ST elevated AMI. And when you know that, you can't wait coming up to the management to give the monotherapy. Now, if you do that, then they might not fail you as long as you mention everything. But again, the best approach would be if you already know by the ECG that this is a ST elevated MI, before even starting the whole history of chest pain, start the monotherapy as accordingly. Okay, so just it would be a good approach.
So we
Any
can do the
patient who
tasks in any order we like. You don't have to do it in the 1, 2, 3 order. We can go in any order with the tasks.
No, normally we should go for it, but like there are some exceptions, like this case, like we are not doing the whole management, just the immediate management, because like every time we are waiting to give a aspirin, some of the part of the patient's heart muscle is dying, right? If we are taking 8 minutes to take history and explain ECG to the examiner, and then we are giving the aspirin, that 8 minutes is on us, because we could save at least a little bit of heart muscle in that 8 minutes. Okay, so that's like for someone who is having a heart attack, that 8 minutes could be like a lot of things. Okay, might be like it's a matter of life and death. So that's why it's important. Like for someone who is having only pain, let's say just a like they had a fracture in the arm, you can wait, and that will not kill the patient if it's not like bleeding that in a long way. But someone who is having MI, we don't wait. We give aspirin as soon as we see that this patient might have. Okay, just start aspirin or just the painkiller, and then you go for your history and everything. Then you can, on further management, you can again say, I have started this for you already. Okay, and then I want to do this.
So should
So
we start monotherapy before the history?
yes, for this one, like if you already get ECG on your screen on the stem, then we can start it. So let's say how I would do this one. So I would ask the invigilator to let me show the ECG because it's saying that it's given outside. So I want to look at the ECG in the 2 minute outside the time. Then I will already look into these things and I will know that, well, this patient is a MI patient. So what I will do, I will go to the patient, and like after 2 minutes is over, then I will introduce myself like, hi, John, this is, hi, David, this is Dr. Ashan, one of the doctors here. I got to know from the notes that you are having a chest pain, which started 30 minutes ago. I'm really sorry to hear that. And it's good that we already did a ECG on you, and I'm looking into that. John, because you are a high-risk patient, you're 50 years, I want you to send you, or I want to locate you to our resuscitation room, and I will ask my nurse to attach a ECG monitor or ECG monitor with you so that I can have a look. And also I will look for all other vitals just to make sure you are stable. Because you are having chest pain, can I ask you how severe is your chest pain in a scale of 1 to 10? Patient says 10 by 10. I'm sorry to hear that. You must be in so much distress. Let me give you some good painkiller. Do you have any allergy to pain medications? No, doctor. Well, I'm going to arrange it for you. You should feel a little comfortable after that. I'm also going to give you a tablet known as aspirin, which you just need to chew, and that will help you to, that will be helpful for your heart as well. Just you can keep the aspirin just for the patient to chew. You don't need to explain at the moment why you are giving it. You can keep that part at the end during the management part. Okay, so just as long as you are giving morphine and aspirin, that's fine, because you don't know what is the oxygen saturation of this patient. You don't need to give oxygen, and nitrite is not mandatory, because if after giving your morphine still patient having some chest discomfort, then you can give nitrite. And also you need to see if this patient having any contraindication to nitrite, any hypertension or not, then you can give it. So as long as you at least give aspirin and morphine, you are good. Once you have done that, you can also say that you will take some blood and send it for, like, especially just talk for, like, you want to do the cardiac enzymes, especially the troponin, to rule out any possibility of heart attack. Okay, so that's the important part that you do. Once you have done that, then you start asking questions. So, John, I need to ask a couple of questions about your chest pain. Is that all right with you? Are you feeling comfortable? I know it will kill a little bit of time to say all these things, but again, you are already half done with your management. So that's not a problem. So then you start, now in here, if you already know that this is a ST elevated MI, you don't need to ask all the differential diagnoses that you are asking. You are asking for someone who is having a chest pain and you don't know the ECG. Okay, like you can just see the task in here, brief history. They know that if you ask whole chest pain differential, in this case, you will not be able to finish these two things in a time. So brief history means just ask about the chest pain questions, chest related differential diagnosis, then ask the risk factor of having a MI, like a smoking, family history, all the ABCD EFS, and then you finish there. Explain the ECG to the examiner. Now in the ECG explanation, very important. Now if you don't know the rate, that's fine. just say that heart rate is normal. Don't say regular, because rhythm is regular. Heart rate is either normal, increased, or decreased, like either normal, tachycardia, or bradycardia, like that. So
Okay.
if you think that, well, I don't have much time to say what is the heart rate, just say heart rate seems to be normal, rhythm is regular, okay? And then you say that the P wave is normal in size and shape, QRS. Now, in here, actually the QRS is showing some kind of M pattern. Now, if you miss it, that's fine. They will not bother with that. But now you know that what is M pattern. So you can just say that if you get something like that, you can say the QRS seems like to have a M pattern. Okay, and then the T wave is normal in size and shape, but I can appreciate ST elevation. It's very good to say where you can see it. Okay, like I can appreciate ST elevation in lead V2, V3, V4, and also in lead 1 AVL. Okay, so I'm suspecting this is an anterolateral myocardial infarction. Now, if you are not sure, or if you're running out of time, if you just say ST elevation in V2, V3, V4, and lead 1 and AVL, and this is most likely a myocardial infarction, or ST elevated MI, they are good with that. That means in here, your main finding is ST elevation. You should always say which lead is involved, because ST elevations, the next question comes that which leads are elevated. Is it an anterior MI? Is it an inferior MI? Is it an anterolateral MI? So we just want to know that, okay? So that's important to say in here. Once you have done that, then further management with the patient. Management in here is very, very important, because you are in a rural area and they already say that you can't transfer this patient. So you can't talk about that you are transferring the patient to a hospital or what they will do. You have to manage this patient in your GP clinic. So what you can do, you will do the monotherapy, you'll send the blood. So you have already done that initially. That's very good. So MONA is the first thing. So you explain what is MI, you reassured the patient. That part was really nice, how you explained. Then the immediate management is MONA. So you can just go through MONA very quickly. Each and like you can say what nitrite will do, what oxygen, when it will be needed, what aspirin will do. So just say very quickly. And then you say that the main management for your condition is either having a PCI or a thrombolysis, because our nearest hospital is 4 hours away and this is a rural setting. There is no PCI available in here. So the best approach in our end is going for a thrombolysis, which is a medication which will dissolve the clot that you are having in your heart blood pipes. But because I'm just a GP, I'm not a specialist in regards to heart, I would talk with the cardiologist over phone, and then according to their advice, I will proceed further.
So we can't say we'll refer to a cardiologist?
No, if you refer, this patient is going to have it 4 hours. Like you can't wait for 4 hours to send the patient to a cardiologist.
Okay.
That's like in here, this is the immediate management. Okay, like you can't wait at all. Like even 2 hours, you can't wait. There is no way we will wait for this patient to see a cardiologist. So what we will be doing in here to save the life, we need to talk with the cardiologist over phone. Like we can talk with the cardiologist available in the tertiary hospital, and they will actually say that, well, you can go for this. We need to also ask contraindications of thrombolysis during our history, because we are going for that. So that's like a lot of things to address in here. And that's why this case is easy, but again, it can turn into a very devastating case.
Yeah.
Okay. But you did good. Your history was very good, but this is important. That's why they have given you these things like rural area and everything, 4 hours away. There is a reason why they're saying that. And they already said that you don't have any option of transfer. You can't transfer this patient.
Yeah. So would the further management be thrombolysis only?
Yeah. So we'll go for thrombolysis. Once the patient is stable, then we can send the patient to a tertiary hospital. They can further, like they can do a coronary angiogram or PCI even if they want at that time.
Okay. Thank you.
Okay. Thank you, doctor. So no need to start oxygen right away. No, Dr. Sodhi. Oxygen only needed if oxygen saturation is less than 94. Should we focus on risk factor and contraindication? We should ask for contraindication of thrombolytics because we are going for that. When to ask for hemodynamic stability? So hemodynamic stability is important if you are going for a face-to-face exam. In case of online exam, it's not mandatory. Most of the time, they already give it to you in the STEM. If it is not given, as I said that during my discussion, I also mentioned that I will look for the vitals. So you can just say that you would like to see that if the patient is vitally stable. Just address that. You don't need to ask it to the examiner like face-to-face. In here, there is no need to go for like a lot of DD question. You can go for like 2-3 differential, especially related to chest and lungs. That's fine because you already know the ECG is given. So rather than going to the whole differential diagnosis of chest pain, you should go through this management and other part because you don't have much time. In face-to-face, you can always talk with the examiner, Dr. Shakia, but in case of online exam, you can't involve your examiner. Examiner doesn't talk. So nothing to do with examiner. You just say your steps that you want, what you want to do. You just explain everything to the patient. Even in face-to-face, if you are sending someone to a resuscitation room, you will talk it with the patient. Okay. Like normally, you don't need to involve examiner too much. But in face-to-face, there is a little difference. Like in face-to-face, if you get someone who is vitally unstable, then you can talk with the examiner that examiner, I would like to send my patient to the resuscitation room and I'll do this. So that time you can do that. We don't need to go for significance of M-shaped QRS, already patient having MI. We don't need to go for it. All right, Dr. Amal, you can't ask it to examiner in online exam. You just say that you will check that. It depends, Dr. Farasha, like everything is there in the GP. Like you don't know that, that's the only problem. Okay, so in your immediate management, you will talk in that way that you will check the oxygen saturation. If oxygen saturation is low, then you will start oxygen. That's what, like not every patient needs oxygen. Okay, and also you will talk about nitrite. Like if you still feel chest discomfort, then I will give you some nitrite under your tongue, which will help to relax your heart blood pipes. We normally would never ever go for thrombolytics in GP setting, but some of the rural GP has some kind of ED setting also. So sometimes they can go for it, but most of the GP setting will not go for it. Okay. Like there are rural GP centers in where they do barhole also. Okay, like that's like super rural areas. You will not find any such history, Dr. Kurat. As I said, always keep the things simple. Don't think too much in exam. If in the history, they would not give something like that. Again, if it's in the real practice, then you need to talk with the cardiologist. They will decide what they want to do. Yes, Dr. Farasha. So same, I already discussed about it, that what you will do. So just go through that. Like you have to send the patient to the resuscitation room, call your nurse, attach the ECG monitor, send the bloods, everything should be done. Contraindications of thrombolysis, we discussed in our class, I think, in our previous sessions. So please go through that. Let's move on to the next case. So obviously, like if someone is having any bleeding disorders, bleeding from anywhere at the moment, having any history of hemorrhagic stroke, any history of ischemic stroke in the last 3 months, okay, any any surgery in the previous 3 months. Okay, so any recent surgery. So these are all complications or contraindications that we don't go for thrombolysis. So management, immediate management is mainly like monotherapy and talking about either PCI or thrombolysis. Okay, this is what they want to hear. Yeah, intracranial surgery in the last 3 months, also a contraindication. Okay, so go through that. Those things you can find it in the Google also, don't bother. Okay, so let's move on. Okay, let's take a 10-minute break. I'll give you some time to think about this page again, and then we'll start again. Let's take a 10-minute break, and then we'll start with the role play again. Thank you all. All right, everyone. So let's just start again. Who wants to go next? Dr. Dolan? All right, so I'll start with you. I also asked it before so that I don't need someone. I'll start with Dr. Haya because I think she asked it first, and then I will do it with Dr. Dolan, I think. There's a lot of you who wants to do role play, I can see. We may not be able to accommodate everyone tonight, but all right. Okay, so let's move on. I'll start with Dr. Haya and then Dr. Dolan. Let me unmute you, Dr. Haya.
Yes, hello.
Hi, I can hear you. That's all good. Okay, give me a minute. I'll give you the case. Okay. Dr. Haya, so yes, I'm unmuting you. Let's do this one.
Yes.
So this is your case. You'll get 1 minute to go through this one, and then we'll start for 7 minutes.
Yes.
Sister.
So I need one. So you're giving me 1 minute?
Yeah. So go through the 1 minute,
Okay.
and then I'll
Yeah.
start.
Yep.
All right. So this is your patient. Your patient name is John. You can start.
Okay. Hi, John. I'm Dr. Haya, one of the doctors here in the GP clinic. Nice
Hello,
to meet
doctor.
you today. Yeah. And from the notes, I can see you had a fall this morning. Really sorry to hear about that. How are you feeling at the moment?
Yeah, I'm feeling good now, doctor. Thank you for asking.
Okay, it's good that you came down to see me for this. I will also help you in every way we can. But before I do so, I need to ask few more questions. Is it all right with you?
Yeah, that's good.
Okay. Okay, can you tell me more about the fall? Like, what were you doing at that moment when this happened?
I just got up in the morning, and then I just had a fall.
Okay, is it the first time you had this type of fall?
No, the previously, like over the last 1 month, I had 2 falls just similar like this.
Okay, and what were you doing at those moments? Were you doing
Same.
any
I just got
activity?
up in the morning and then I just had a fall.
Okay. And by any chance, did you had any blurring of vision, any headache before getting that fall happened?
No, doctor.
Okay. By any chance, did you hit your head?
No.
Okay. Did you lose any consciousness?
Yes, I lost consciousness this morning also.
Okay. Was there anyone witness your this episode?
No, I live alone, so there is no one in the home.
Okay. So would you mind like telling like how what was the time you felt about like how long you were unconscious?
I don't know, doctor.
Okay. Any jerky movement did you notice?
No, I
Okay.
didn't notice anything.
Did you lose control over bladder or stool?
No,
Any tongue biting by any chance?
no.
Okay. So when you like got the consciousness, were you okay enough to walk?
Yeah, I was good then.
Was there any drowsiness, any confusion after that?
No,
Okay. And can you tell me like these days, have you noticed any chest pain, any racing of heart,
no, doctor.
any nausea, vomiting,
No,
any shortness of breath by any chance?
no, no,
Okay. Any weakness in any part of your body, any vision problem?
no, doctor.
Okay. Do you like miss your meal by any chance
No.
today? Okay. Do you have any history of diabetes?
Yes, doctor. I have diabetes.
Okay. May I know from like how long?
It's been for 10 years, I guess.
Okay. So are you up to date with your GP for the diabetes?
Yeah,
Okay. You are taking your medicine regularly?
yeah.
Okay. So is diabetes under control? Have you recently checked it?
Yeah, my GP told me that it's all controlled.
Okay, okay, that's very good, John. And can you tell me, do you have any kind of weather preferences? Do you feel hot or cold while other people in the same room doesn't feel it?
No, doctor.
Any recent vomiting, diarrhea by any chance?
No,
Okay, do you feel tired these days?
no,
Any kind of stress?
no, doctor.
Do you think like your fall is connected to like associated with the posture changing whenever you change the posture from sitting to standing? Do you think it's like that?
It could be because I feel really dizzy when I get up in the morning.
Okay, okay. I can understand, John. Do you have any past medical history of increased blood sugar, blood pressure by any chance? Like
I
sugar, you
have
told me
blood
about blood
pressure.
pressure. Okay.
Yes,
Sorry.
I'm having high blood pressure.
Okay. So do you take any medicine for that?
Yeah, I'm taking some medications. If I'm not wrong, it was one is Remipril, and another
Okay.
was one of the diuretics. They say I can't remember the name.
Okay. 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 It's okay. Don't worry. And along with that, do you take any alcohol or do you smoke?
No, doctor.
Okay. Any kind of allergies by any chance?
No,
Any history of a heart condition before?
no, doctor.
Any family history of heart condition by any chance?
No.
Okay, okay, that's very good, John. Okay, thank you for the history. And I have done some examination on the you, and actually I found out that blood pressure is like I can see some there is drop of blood pressure after you stand up. Like pulse is also normal, oxygen saturation is good, but the JVP and all the things are normal. Like I did all the systems. The heart is normal and heart is also good, and your lungs are also very good. There is no edema, nothing is there, and I can see some sugar is increased, and also your like ECGs, we did some ECG, and it shows like slowness of your little bit slowness of your heartbeat. Like this normal, it is slow in nature. According to that, John, what I think is you're having a condition called like postural hypotension. Do you have any idea about that?
No, doctor. What's that?
Actually, John, what happens is when you stand from sitting position, sometimes there is pooling of your blood into the legs, and it does not reach your brain and heart properly, and you have this type of fall. Like it has a lot of reasons behind it, John. Like maybe due to increase, I can see some diabetes. Also, your diabetes is little bit, sugar is increased, and I can see like you're taking some multiple drugs, like the sugar drug and hypertension. Sometimes the interaction of those drugs also can cause this postural hypotension, but it can be due to many other reasons, like it can be due to any heart attack, but most likely in your history it doesn't seems like. It can be due to any stroke, which is the blockage of any vessel in the brain, also can cause sometimes weakness. So it can be due to any electrolyte like salt imbalance in your body, but doesn't seems like at the moment. It can be due to any thyroid condition, but it is also less likely. Yeah,
Time
there
up.
can be a lot of reasons. So are you with me so far, John?
Thank you, doctor. Time up.
Okay.
All right, Dr. Haya, right? So thank you so much. It was really nice. I would say you finished like in time. That's very good. Now, I think like you touched most of the important points, and I'm happy with that. I think that what we can add in here is that let's say that he had a fall happen this morning. You can say that you would like to check his vitals just to make sure he is
Okay.
stable at the moment. If you don't even say that in online exam, that's totally fine.
Yeah, that's
Now,
right, because everyone is saying like about that
yeah,
vital
yeah,
stability.
they're like
Yeah.
it depends. Like many
Okay.
are saying that if it is written in the stem, like most of the time it's
Okay.
written in the stem that vital is stable, then we don't need to even talk about it. But if it's not written, then we can just say that I'll check your vitals and make sure you are all good before going for history. Now it's totally up to the candidate if they want to say or
Yes.
not. It's not nothing like critical error or anything in here. Okay, so then you start asking question with the fall. So what exactly happened? So you ask all the pre-syncope, syncope, and post-syncope questions. That's all good. You ruled out severe CNS related differentials. Now you can directly ask. So you ask at the end, I think, like, is it related with changing positions? That was important. And
Yes.
like when you get it, yes, that means you know that this could be a postural hypertension. Ask the underlying causes of postural hypertension. So give it more focus on that. What can cause postural hypertension in a 65-year-old? So we want to find out if this patient having any recent fever, any sort of infection anywhere. Then we want to find out if this patient is bleeding from anywhere. Okay. We want to find out if this patient can have any excessive medication, like any hypovolemic medications that we have asked. It could be cancer also, we don't know that. Like sometimes patient can have it. So we can ask the patient loss of weight, loss of appetite related questions. So those will be important. Like another one is like when you got to know that this patient is diabetic, he's well controlled, but still it could be a diabetic autoneuropathy causing postural hypertension. So you can ask some diabetic autoneuropathy features like heartburn, any change in the bowel habit like diarrhea, constipation, sexual dysfunction, even the very unlikely like 60, 65, even like they can be sexually active also, you don't know. So you can ask about their sexual life as well. That's okay. Any bloated sensations, okay, and just very quickly ask about diabetic related complications like any change in your vision or hearing. You can ask about any change in the any change in sensation in your food. Just ask a couple of questions in related to diabetes, just to be like aware, because there is a case something like that, right? So we don't
Yes.
want to miss. Also, someone having fall, remember, we want to ask them about their home situation. So who do we live with? Do you have enough support at home? We want to find out, is there any like any lack of um, any poor lighting in the home? We want to find out any loose carpets, because these are very important to rule out in a 65-year-old. So we always ask
Yes.
their home situation. So we can ask those questions in here. Now, the important part that I want you to add in your history, even though you miss all of it, that's okay, but you can't miss the medication part. That means you find out this patient is taking some blood pressure medications. So I said that I got Ramipril, I'm getting some diuretics. Ask the patient, have you increased or have your doctor increased any of these medications recently, or any of this medication has been added recently? Because that gives you the finding that either it has been increased dose or a new drug has been introduced. So that could be the possible reason of having a push-wall hypertension at this time. Okay, so always we ask that. We can ask about joint problem also. That's fine. So arthritis, you can ask, yes. Okay, so all these
Doctor,
questions
may
will
I
come
ask
in.
one question?
Sure.
Yeah, like overall, how do you assess my station? Like the way I performed. So will I get some passing score on that, or like the things I
Yeah,
missed will get me like a failure in this case?
I don't think so. It again, like it's no one can say that you will fail or pass this case because it's totally like examiner thinking. But in my
Okay.
view, you might pass this case. But again, like it's the soft examiner. If I am a soft examiner, I will pass you. If I'm a hard examiner and I don't want to like pass a lot of candidate, I want to pass just a specific 2 or 3 candidate. I'm something like that examiner, then I will not pass you. So that's the thing. So if you get a tough examiner, so in AMC exam, there will be some soft examiner and most of them are hard examiner. So in those situations, you have to get into those questionnaires. That means like if you're thinking is as a push-wall hypertension, the examiner expect from you to ask those medication related questions more. Okay, so that's important. Like some very tiny things like can change the whole outcome of a station.
Yeah, because I thought I will ask, are you up to date with the diabetes and all the drugs? So I thought maybe patient will himself will give, yeah, recently the drug was
No,
increased, but yeah, I should ask
they
the
will
regulator.
not.
Yeah, yeah.
They will
I thought
never give
that.
you the most important thing. You need to always
Yeah,
ask it. Don't think that
yeah,
they will
yeah.
give it to
I got,
you.
yeah. Okay. Thank you. Thank you so much.
No worries, thank you. So that's all good. No, no, Dr. Misbah, not exact cause. You give some possibility, right? So one of your task number 3 is still diagnosis with reason. You say push-wall hypertension. So you explain what it is. So it's a like change of blood pressure when they change their position from sitting to a standing position. Now, why it's occurring? That's the reasoning. So it could be due to many reasons. But for this patient, I'm suspecting about the multiple medications and important like the medications maybe recently been added or increased dose. That could be a possibility. The second possibility, like give the other reasons of push-wall hypertension, like any recent fever, any bleeding from anywhere, okay, any recent diarrhea, vomiting. So these are main causes. It could be diabetic autoneuropathies. Like just say, you don't need to even explain like diabetic autoneuropathy. Just say it could be a complication of diabetes like diabetic autoneuropathies, but you don't have these symptoms and you're well-controlled diabetes. So nothing to worry about on that. Now, is this, if some blood sugar is given in your PFE card, it will always be a random one unless it is saying fasting or postprandial. Random, what is the normal? Less than 11 is normal. So it's all good. It's not very bad PSL. Okay. So that's okay. So just remember those values. Sometimes, most of the time, they give you the normal values, but again, like normal blood sugar should be like just memorize the blood sugar levels. Okay. And what else? One of the things in here, you can see the pulse rate. I think like Dr. Haya told it as normal. It's not normal. Normal pulse rate is 60, right? So that one of the reason you should always address here. Sinus bradycardia can also cause kind of like feeling dizzy. We need to go into the bottom of it. Why this patient is having sinus bradycardia? Is there any other heart block or anything going on with this patient? So we just, at least we need to say in our reasoning, this finding that we have got, because bradycardia can cause someone having a dizzy feeling. So just address these issues. We don't need to ask about melena, but bleeding from anywhere, that's one question we ask. And we also ask about bowel habits. So in the bowel habit, you will cover melena. Yes, who asked? Dr. Gulona, very good question. Yes, bradycardia, at least we should say in our reasoning that this could be a possibility. If you get something in your physical examination card, always address that in your management or diagnosis. That's very important. That's given for some reason. Yes, Dr. Irsa, that's right. Yes, for postural hypertension, those are the main causes. So you just say, Dr. Alice, that yes, I've also found your pulse rate is a little lower than normal. Normally it should be 60, in your case it's 45. But the ECG that we have done is showing a like sinus bradycardia, which means that you are having some changes in your heart conduction pathways. But obviously we might need to do some more investigations to find out is there anything else there. Okay, but again, this bradycardia means that your heart is not pumping enough, and that can also be a cause of your feeling dizziness or even this fall that you are having. Okay. We don't need to ask binging like recreational drugs in 65 years, but alcohol, at least alcohol history is very important. Yes, it can be hypoglycemia. Obviously, we should always ask it. Like all the syncope and fall differential diagnosis should be asked here. Okay. All right, guys. So let's go on to the next case. I think Dr. Dolan wanted. So let's start with Dr. Dolan. So there is nothing like that, Dr. Farah, but normally if alcohol is more than 2 standard drink every day, that's needed a counseling. And smoking, like any form of smoking, is bad. But if someone says occasional smoking, it's nothing to worry about at the moment. Dr. Dolan, do you want to go for it or Dr. Wafi will go for it? Okay, I'll unmute you. We might just finish here tonight with Dr. Dolan. Okay.
Hello,
So
doctor.
let's do a case. Yes, I can hear you.
Thank you.
Just give me a minute. So we have done most of the cases. I think. What else we can do today? Oh, okay. Let's do a fun case. So Dr. Dolan, this is your case. You'll get 2 minutes for reading this case and preparing yourself. Then you'll get 8 minutes to finish this one because you have 4 tasks.
Okay.
Okay, so this patient name is Sam. You can start.
Hello, I'm Dolan. I'm one of the doctors here today. So Sam, I'm not from the notes. I can see that you are having some chest pain. Can you tell me more about it?
Yeah, doctor. I'm having this like weird chest pain like for the last 2 hours. It's not new for me, but it happened on and off for the last 6 months.
Okay. And do you have pain right now?
Yeah.
Okay. Can you score the pain for me? 1 being the least and 10 being the most?
It's 5 or 6.
Okay. So does the pain shift to anywhere else?
No, doctor, it just stays there.
And is this suddenly appear?
Yeah.
And is what type of pain it is? Squeezing, you said?
Yeah, it's kind of squeezing, and sometimes even I feel like something is burning in my chest.
Okay. And do you think anything makes it worse or better?
What do you mean by that, doctor?
Like a deep breathing, or while you're doing activity, it makes it worse?
Not really.
Okay. And do you think that this pain is relieving by leaning forward?
No.
And do you think that this pain is any relation with the food?
Yeah, sometimes I like when I take some spicy food, I get this pain.
Okay. And do you think that this pain is spicy food? Okay. And how often do you have spicy food?
Not much. Previously, I used to have a lot of Indian foods, but I stopped that. But actually, last night I had one, and then like I'm having it like since the morning, and also now I'm having it.
Okay. And okay. So and do you have any shortness of breath or any rapid racing of the heart?
No,
And do you have any fever or flu-like symptoms?
no,
I can see that you are having this pain for the last 6 months, right?
yeah,
Are you taking any medication for that?
no, doctor.
Do you think that way if you it relieves by drinking milk or something like this?
I haven't tried.
Okay, okay, no worries. And what about do you smoke, drink alcohol?
Occasionally I drink, but no smoking.
Okay, and any history of binge drinking?
No,
Okay, and what about and any nausea, vomiting?
no, doctor.
And have you noticed any cough?
No,
Any what about your pee and poo?
yeah, it's all good.
Okay, any tummy pain you have?
I have some kind of like tummy pain, like in the upper part of my tummy,
Okay.
and it's
Uh,
also on and off. It's mostly come with this chest pain after taking those spicy foods.
okay.
I'll
And
probably just stop that.
okay, that's let's see what we can do for you. So, do you have any past medical or medical history, like any high blood pressure, cholesterol, or high sugar level?
No, doctor.
Okay, and any family history, any of those?
My father had a heart attack.
Hmm. John, tell me about. Do you have any history of gallstone, like stone in the tummy? Anyone told you before? You have any investigation or anything?
No,
Or anyone in the family have this type of symptoms?
no, doctor.
Okay. And what about are you aware of your BMI?
No, doctor.
Okay. And what do you do for a living?
I'm a banker.
Any stress at work or home?
No,
Okay. And any history of a joint problem or kidney problem?
no, doctor.
Have you recently traveled anywhere else?
No,
Okay. And what about what is the term? Um, So, okay, history looks like okay. Okay, John. Do you want to share anything else?
No, doctor. Do you want to ask anything?
Are you taking any medication for anything?
No.
Have you recently tried any over-the-counter drug?
No.
Okay. And any weight loss do you have, or any loss of appetite?
No.
And have you recently noticed? Okay. Okay, and I don't know what to ask next.
Move on.
So the physical examination card I will get, or I need to ask you from you?
Ask.
Okay. No, there is a PEFE I can see. That's why I'm asking. So examiner, I want to do some investigation of my patient. I want to order some.
Physical examination is all normal. Move to the next task, doctor.
Thank you. So I want to order the physical full blood examination with inflammatory markers, and I would like to do order refer the patient for upper GI endoscopy, and ECG of my patient. And okay, told you what it looks like. Okay. See picture of can I go back to the task? Okay, so I need to explain the diagnosis and differential diagnosis. So John, there could be several reasons that you are having this type of chest pain. It could be due to my most probable diagnosis, you are having a condition is called gastroesophageal reflux disease, which is a condition when our lower part of the esophagus, which is
Thank
the
you.
pipe. Okay. Do you want me to stop, doctor?
Yeah, that's fine. So you got the diagnosis. That's what I wanted to hear. That's fine. Thank you, Dr. Dola. So this case, like the one thing that I was thinking, Dr. Dolan, that you're doing good. So why, like, if you think that you don't have any question to ask, that means you asked every questions. Okay, so don't like wait, because you have a lot of tasks in here. Move on. Just like whenever you finished your chest pain questions and you touched some of the differential diagnosis, you are good with the history. Okay, so they don't want everything from you. So, and also you got a finding like this chest pain is related with the spicy food, right? And everything is going with like either it's reflux or peptic ulcer disease. We don't know that. So any of these two different diagnoses will be fine. So
Doctor,
then,
there is a PFE card. I thought it will appear after 6 minutes or something. That's why I was waiting for.
is there anything written in here like a PFE card will be appearing after 6 minutes? Nothing. So if
Actually,
like don't think anything which is not written in here. Okay. So that's the point. Like a lot of candidates also think that if this will happen, but it doesn't happen, right? So if something is not written in bracket like that, it's not going to happen. So don't dream about that in the exam. It's very important. Like this case actually, like I was supposed to actually explain to you, but I think I forgot about it. But the PEFE means physical examination from examiner. So like if something is like that, it's actually a face-to-face one, but that's fine. Like if there was a card given, then that's okay. But again, like this 6 minute, 5 minute thing, don't think that it will always be there. Okay, if it is there, it will be written in here very clearly, like card will appear on the screen after 5 minutes. So it will be a very, like everything that's going to happen, it will be written in the screen. Okay, nothing will happen which is not written in here. So don't think that. Okay, yeah. And like your history was perfect. So you like one thing that I would say, like 50-year-old having a 2 hours duration of chest pain, you can always think it as MI. Okay, because it could be, this is the most likely reason. So you can just at least send the patient to a like treatment room or resuscitation room, do the necessary thing, because that's the point, right? So even though it might be just a gastroesophageal reflux, looking at this case, it doesn't look like that. Squeezing chest pain, 2 hours. Okay, so it could be a MI. So always be like in a practical way, what we would do. We would obviously think it as a MI, but if we do everything, we don't find anything, that's okay. But always we have to be cautious in these cases. So start just like a AMI patient, and then you take your history. You get nothing positive that's going with MI, that's fine. You go for all other differential diagnosis, move on. Just don't think that you missed something. If you miss something, you can again come back.
Okay.
And then you ask the PFE will be normal in here most of the time. Ask investigation from examiner. So obviously ECG, you talked about endoscopy, that's fine. You can add some basic blood test. Explain investigation to examiner. That means you have to explain the ECG. This is yours normal ECG. Okay, that's why I say that this is a fun case, because it's fun, right? But not fun for me, but not fun for you. So this one, like in exam, be prepared for anything. Like normal ECG can happen. It's just to confuse you, right? And there is a lot of like this happens in real life also. Like you're thinking it as a AMI, but troponin comes normal, ECG comes normal. So it's just a reflux or just a peptic ulcer. So always be prepared. So normal thing can also happen. In exam, it doesn't mean always has to be abnormal thing. So don't get scared if something comes as normal. People get more confused if they get normal finding rather than abnormal. Okay, so that's the common thing. So like if something is normal, then say normal. If you don't find anything, there is nothing. So most likely diagnosis, if you give reflux or even if you give peptic ulcer disease, that's fine. And DD will be all the chest pain differential diagnosis. In the differential diagnosis, I was thinking that it would be a good idea to ask about other, like you can ask about any trauma to the chest to rule out pneumothorax. You can ask about rash over the chest to rule out herpes zoster. Is the chest sore to touch to ask costochondritis? So all these things would be good. Okay, so I can see a lot of questions. Let me go through the questions. What happened in here? So yes, anemia questions we can ask here. So something like if you get a patient having chest pain and that's most likely reflux or abdominal related, in this age group, we will always rule out loss of weight, loss of appetite. Like it could be a cancer, we don't know. Like it could be a gastric cancer also. So always rule that out, like bowel habit, bladder habit, are they bleeding from anywhere, any previous history of doing any endoscopy or colonoscopy, just ask it. Okay, yes, it could be an angina due to anemia. Okay, so ask those questions. So especially ask, like if it is an anemia, you will get finding in the physical examination that patient is pale, or patient might feeling tired, or someone told that they look pale these days. So something we will get if it's an angina due to anemia. So if examination normal, ECG normal, we don't think about even angina due to anemia, okay? You'll just say about gastroesophageal reflux at that time. So your history is very important. See that like we only come to a diagnosis based on our full history and physical examination, because this case can be angina due to anemia. If I would give you like, I'm feeling tired these days, and so that would be an angina due to anemia case. Doctor, how to ask investigation from examiner? You just say that, dear doctor, I would like to order some investigations. So I'll start with full blood count, kidney function, liver function. Okay, and I'll also order an electrocardiogram, and also this patient will need a endoscopy and colonoscopy. Just say in that way, like whatever investigation you want to do, just mention those investigation. Yeah, it's a very good idea to reassure this patient that it's not a heart attack. Offering painkiller, even if it's a 5 to 6 in pain scale, you can always offer painkiller to them. In here, again, Dr. Irsa, we would always think it as a MI, so we will send the blood for troponin in this case also, because sometimes maybe it could be a MI, like a non-ST elevated MI. We don't know that. So always we have to think about it. Yes, you can ask it, Dr. Misbah. Office test, you can always ask it. Now, in this case, there is investigation from examiner. So office test, you can just add it here. So you don't need to specifically ask it. Yes, Dr. Orhi, if in the stem, anytime blood sugar is low, you offer a glucose drink. Sometimes can present with no symptoms. If anemia is like just a mild anemia, it may not have any symptoms. Angina will have normal ECG, that's right. But the thing is that you might get, the PFU will not be normal. Okay, in case of angina due to anemia, pallor will be positive at least. Yes, you can do that in the investigations. Like initially, if you think that in this case, we can order like H. pylori test, like we are going for endoscopy. For this patient, if it's a reflux, we need endoscopy. Okay, it's a 50-year-old. So endoscopy at that time, they will do a urease test on that endoscopy specimen. So we don't need to even do the urea breath test, but that's fine if you mention. Yes, Dr. Jean, this will be uploaded in your software, and also the answers, like not the whole answer, because most of these cases we already discussed in our class. So you need to go through the theory classes and just go through the feedbacks from this from the software. There are feedbacks for these cases. You can go through that in the software. That's fine. So physical examination from examiner, we discussed about it, Dr. Alice, like how to explain how to ask physical exam from examiner. So you just need to ask every finding from the examiner. Like if it's a chest pain, then you focus on the CVS physical examination. If you are still having any confusion, go through our cardiology lectures, the 2 lectures that we have taken. It should clear your any confusion. Dr. Misra, that's a good question. Like, I think Dr. Dolan also asked me, do you have anything to tell me? Trust me, never ever they tell anything to you. Okay, so if you ask that question, you will, most of the time you will get back like, do you have anything to say? So that's a waste of fake time. Don't ask that question. They will never say anything. Don't think they are friend to you in the exam. So I think we'll finish it here tonight. Dr. Dolan, you did good. Don't worry, you were in the correct way. And because you were asking questions appropriately and everything, so you just need to make sure the time is well balanced. That's fine. Okay. All right, guys. So any questions? If I missed anyone's questions, you can ask me. All right. In the next class also. So we will have one more free sessions with you. That will be your pediatrics vomiting cluster, I think on 4th of September. So that will be our last session, like 2 weeks free sessions. I guess that most of you already know how we take classes. And if you want to join the course, this is the high time, because this is the last week we are doing the admission. Up to 7th September, the admission will be open, and then we might close that. Okay, so if you're still not sure to join, there is another class on 4th on pediatrics, and then we'll have like, I think 3 days time left to get admitted, because there will be an orientation class with those who got admitted. We'll just go through that, how we do everything, the classes and everything, just an orientation class, and then we'll start our course as a full-blown one. Okay, so I hope you guys are enjoying the sessions. That's all that I want to hear. And if there is any questions about the course, feel free to ask me now, or you can always reach us through Messenger or email. There is a lot of posts you get in the Facebook group, so you can always go through that. Any question, those who are in Facebook? And always remember, like there is, like if I say that this is the only correct way, this is not right. Okay, there is a lot of correct way in your table. You just need to pick one and just follow that. And it doesn't mean that my way is only the correct way. Okay, so as long as you touch all the most important points in the exam, you are good. Okay, so it's nothing like that. Like if you don't say stability at the first, you will just fail the case. So it's not like that. So don't think in that way. Think that you need to touch those points. Okay, anytime in that 8-minute time, you need to touch those points. However you touch it, that's fine. And as long as your approach is good, remember one thing, you are not assessed as in just one specific point. As a whole, you are being assessed in the exam. By the end, even if you miss something important, but everything is good, your approach good, role player likes you, examiner liked you, you will pass the case. Even if you forget to finish differential diagnosis, you might pass the case. So there's a luck, and depends on your approach most of the time. No, the task should be in order. Okay, the thing is, like if history is in task, history, physical examination, and then management. You are not going to do the physical examination before history. So that order you would never break, right? So that task you should never break. Like if there is a result given on your screen and the first task is explain the result to the patient, you should explain it first. Okay, so those order are there because that's the perfect order. Okay, guys, so thank you, everyone. We'll see you in the next class on 4th of September on pediatrics. Thank you all. Have a good night.